My name's Tim. I've lived in Essex most of my life. I'm 49 this year. My dog really is my life. She's my first ever dog, and she's just such good fun. I was diagnosed diabetic type 1 on my 14th birthday, which is a great birthday present. You feel like you are given a list of all the things that if you don't do this, this will happen to you. And I can recite that list as being blindness, heart attack, stroke. And at 14, that's what you're given. So that is a huge thing to actually process in your head. Amputation was never one of them. I thought, well, you know, I am fit, I am active. I never saw that as being an issue. I mean, my first actual amputation was 4 years ago. I had a toe removed. The actual foot ulcers probably started about 2 years before that. The ones before, they were fairly minor, they were treated, they recovered, they weren't too bad. The last one was the most severe, and I think the results from that and everything else that occurred as a result of it has actually terrified me. I was at a friend's wedding in Greece and I bought a new pair of shoes for the event. I remember leaving the reception to go to the loo, and as I was coming out the loo, there was a trail of blood across the floor, and I took the shoe off. Literally, all the skin on the ball of my right foot had just completely come away. They told me from the get-go that for it to recover, you basically need to offload all the weight on your foot completely. In an ideal world, fantastic, but even when you're working, you can't just sit down and put your foot up for an entire day. Being a diabetic, sometimes I get hypos at 2 o'clock in the morning. I'd get downstairs to get a bowl of cereal, sort of hypo out, and there would be a trail of blood all down the stairs where everything had just literally seeped through the dressings that were on there. The worst thing, and this is really gross, is the smell. When it gets to the point when your partner says, "I'm sorry, but I can't sit on the sofa next to you because I can smell your foot." The mental impact of that is hideous. It wasn't getting any better, it wasn't recovering, it wasn't shrinking. I eventually got diagnosed with sepsis. So, rushed into hospital, and my foot had literally blown up, and the skin was starting to peel away from the top surface. I got admitted on the Sunday. On the Tuesday night, they put me in intensive care, and summoned my next of kin, and said, "This is it." That was the most frightening it ever got.
Hi, and welcome everyone to our today's presentation, Get Your Patients Back on Their Feet Sooner, introducing the UrgoStart Plus Treatment Range, brought to you today by Urgo Medical. And it's my pleasure to moderate and introduce this session today. For those of you who don't know me, my name is Kimberly LeBlanc, and I am currently the Academic Chair for Nurses Specialized in Wound, Ostomy, and Continence Canada, and I'm an advanced practice nurse with KDS Professional Consulting. And today it's my great pleasure to introduce our speakers. So I will do my best to pronounce names properly. First presenter I'd like to introduce you to is Kristien van Acker. She completed her internal medicine and diabetology training in 1989 at the Antwerp University, where she founded the first multidisciplinary diabetic foot clinic for Belgium. Her PhD thesis titled "The Diabetic Foot, a Challenge for Policymakers and Healthcare Professionals." Since 2001, Dr. van Acker has gained extensive experience in the field of diabetic foot education. She founded and chaired the Train the Foot Trainer projects executed for the SACA, the Caribbean, European, Western Pacific, French-speaking African region, and recently in the Middle East. She has published many peer-reviewed articles, book chapters, and books. She is clinically active as a diabetes consultant and runs outpatient multidisciplinary diabetic foot clinics. She was a consultant of the Tropical Institute in Antwerp and a lecturer on public health and chronic disease management. Today, she is the medical director at the Hospital of Chimay, and she is the founder and the former president of Diabetic Foot International. Our second speaker is Jeanette Milne, and she is a Chief Matron for Community Service at Northumbria Healthcare in the UK. She provides both the strategic vision and operational management of the community nursing, specialist nursing, and tissue viability teams. She has a passion for wound care and has earned a postgraduate diploma in wound healing and tissue repair at Cardiff University. Jeanette has published a number of articles and is particularly interested in the impact of outcomes of care delivery. She's a national and international speaker and is actively involved with the tissue viability and leg ulcer courses in the capacity of honorary lecturer at the university. Jeanette is an active member of the editorial board for Wounds UK and British Journal of Nursing. So I think that you would agree that we have a great lineup of speakers for you today. And I'd like to remind you to please put your questions in the question and answer section. I will be keeping track of them throughout the presentation, and we'll open them up for our speakers at the end of the lecture. So just to start things off, I want to bring a little bit of a Canadian perspective to this topic. And, you know, some of the stats are kind of astounding. So I did a little bit of reading and discovered that 2 million Canadians have diabetes, 6% of our general population, 20% of the population are over 70 years of age, 30% of the Aboriginal population or our Indigenous population, with more than 20 Canadians diagnosed every hour. So that's kind of staggering. And we know that there's major complications that come along with diabetes, including myocardial infarctions, cardiovascular accidents, angina, heart failure, neuropathy, and blindness. But, you know, what we often minimize and overlook is the impact of that neuropathy and how that impacts our patients. And we know that this really impacts our number of diabetic foot ulcers that we have and the amputation rates. And if we look at the 5-year mortality rate of diabetic foot ulcers, we see that it equals all of cancer. And, you know, major amputation and minor amputation, you know, it's greater than all cancer diagnoses combined. We know the mortality rate for people who undergo lower extremity amputation due to a diabetic foot ulcer is alarming, and that 70% of people with a major amputation will not be alive in 5 years' time. So really, those are huge statistics. And we know that it's a major disease that we really need to be looking at. And, you know, for me as a clinician, it's heartbreaking when I see the number of people that come into my clinic and it's already too late. So we need to do better. We need to look at how we're managing these patients. And we know that 1 in 4 people with diabetes will potentially develop a foot ulcer. And a recent meta-analysis showed that nearly half of patients with diabetic foot ulcers had depression or other types of mental health issues. And we know that a foot ulcer left open for more than 30 days is 4 times more likely to become infected. And we know that individuals with diabetes have a 25% lifetime risk of developing a foot ulcer with an annual incidence of 2%. So those are huge statistics to look at. If we look at the impact on Canadians, we know that 4 to 24% of patients with diabetes and leg or foot ulcers will require amputations. And that diabetes has become the #1 cause globally of amputations. So the global statistics are staggering, that there's an amputation every 20 seconds related to diabetes, and that's on a global level. And that 70% of amputated patients will not be alive in 5 years' time, as we've already stated. So, you know, this is quite impactful when we're looking at how this is impacting Canadians and our healthcare diet, you know, our healthcare dollars. And we know that 85% of these amputations could be prevented if we had the right education and the right care. So if we look a little bit further and we look at the rate of venous leg ulcers, you know, this is something else that often, you know, we often overlook. And we see that 2 per 1,000, and the rate of reoccurrence is 50%. And any of you who've ever taken care of anybody with venous leg ulcer will notice that they often see these patients over and over again over the years. And that leg ulcers can take over 200 days to heal on average. So they're not a quick fix. So we need to be doing a better job at preventing. And we also know through a lot of the great work done at the Lindsay Foundation that, you know, many patients with lower leg ulcers talk about feeling low or depressed. They experience pain, loss of sleep, feel restriction in their functionality, and it greatly impacts their quality of life. So let's look at some of the costs associated with diabetes, and these are huge. So the total cost of a diabetic foot ulcer is $547 million. Healthcare services is our annual cost, and a lifetime net, when we modeled it, is over 600,000. So we look at this, and then we look at the lifetime net model cost of a venous leg ulcer in Ontario. You're looking at 548,000. So we're looking at huge numbers of healthcare dollars that are contributed. And this doesn't include our human costs that we already talked about in terms of depression, loss of work, loss of function, and the emotional toll that this takes. And we know that, Canada alone spends $1.5 billion on direct costs of amputations in individuals related with diabetes. And, this further goes into, we look at data from 2011 that showed that 34% of individuals with diabetes had an admission to the emergency department. And, which is consistent with a diabetic foot ulcer, but they were never coded as such. So a lot of the numbers, what this means is that a lot of the numbers in terms of how much we're actually costs are hidden, and we don't know because they're not being coded properly when they come into the hospital. So they may be coded for diabetes, not a diabetic foot ulcer. So we may not know the true numbers. So, some of the things we want to know is, what if more could be done? So what can we do as healthcare clinicians to reduce the healing time of these chronic wounds, particularly diabetic foot ulcers and venous leg ulcers? So how can we reduce those healing times? So we want to make every day count. That's something that's extremely important. We want to make sure that we're examining patients and that we're looking at how can we improve those outcomes. So, we've already talked about the fact that, the amount of healthcare dollars that are spent and how we can do better in terms of managing healthcare dollars. But I think we need to look at healthcare professionals' knowledge, attitude, and practices as well. Because we know that fewer than 20% of physicians and nurses actually ask individuals with diabetes to remove their shoes and socks at every visit. And just think about what we could do if we just had frontline primary care physicians and nurses looking at people's feet at every visit. And, Dr. Sibbald has done a lot of work looking at the INLO 60-second screening tool, and the fact that in 60 seconds you could actually prevent a diabetic foot ulcer. So we need to be looking at how we can prevent these wounds. We need to do better. We need to look at how we can reduce healing times. And, we know that there's lots of best evidence and based treatments out there. But what we need to look at is how can we get the patient pathways with referral to the specialists in a timely manner? How can we get that dialogue with our patients to make sure we have their buy-in and that they're working as a collaborative team with us? How can we get that early and accurate diagnosis? And this is all part of a holistic approach that we can use to reduce healing times. So I challenge you, as I turn the rest of this lecture over to our esteemed speakers, is to think about where your practice is at now in Canada and how can you take this holistic model and look at changing your practice. So at this time, I would like to pass the presentation over to Kristien to talk to you about some of the evidence and guidelines for local treatment of diabetic foot ulcers. Kristien?
Thank you, Kim, for the nice introduction, and welcome to be with us together. And honestly, I feel really honored to be linked again with a wonderful passion group in Canada, as I was with you last year. The topic here is the clinical evidence and guidelines for local treatment of diabetic foot ulcers. UrgoStart, sucrose octasulfate interacting dressings, the highest level of evidence ever in wound care, and we are proud to share with you. We all know that if we have to go through literature and expert opinions, that is the lowest level. And the more, if I look back to my career, we were better and better in wound care to go to good analysis. And of course, the highest level we all know is the meta-analysis and systematic reviews. So we have done, and Urgo especially, really interesting studies, also on the lower leg ulcers, but for my part, it's more important to tell you about the diabetic foot ulcers. And you see, and we will not go in detail to all the studies. I think I want to share with you, for me, it was really exciting study. It's the Explorer study, a double-blind randomized control studies versus neutral dressing for neuroischemic, and that's important to take this clearly in your mind. It's neuroischemic diabetic foot ulcers with 240 patients. What is the study about? Explorer study, robust randomized control study demonstrating unprecise efficacy in diabetic foot with the TLC NOSF. 240 patients. Remember, many of us were involved in neuropathic ulcers. Now we are talking particularly what we see today the most is neuroischemic ulcers. Treatment versus neutral dressing. Standard of care was there in both groups. So here I like to show with you how it was set up. It was a run-in period to be sure that inclusion and exclusion criteria were well validated. Then we had the two-arm study group with the control group and with the TLC NOSF. And there you see clearly that the criteria were very well selected, were well set, but also, and I think that's one of the best ever, offloading compliance was confirmed in the both arms. So there was a real optimal standard of care as we all wanted to have in this kind of studies and also in really life, daily life. Then of course the follow-up arm that was performed. What came out? I think some data were so impressive that we have to remind them. A reduction of healing time, 60 days. 60 days. It's tremendous because it's not only costs, it's also the suffering and the anxiety the patients have to have complications related to the ulcers. So, UrgoStart dressing significantly increased the rate of complete diabetic foot ulcer wound closures versus standard of care alone. And looking further to details, you see here that the analyzers showed us the difference here with the 60 days I already mentioned to you. Coming to the standard of care in both study arms, offloading, really well monitored to be sure with diary, debridement done as we wanted to have in both groups, and hyperkeratosis removal. So you remember they are not the same, but it was all under supervision. 60 days, time to complete wound closure is 60 days sooner. That's one important thing. Another question that came later when we went further on in the details of the study is to ask ourselves, was this all over the time, or was there a difference if the wound in the early was less than 2 months, between 2 and 5 months, and further on? And now another element was very important to really have a statement on. First intention treatment, the sooner the better. Here you can read it again what I wanted to say. The difference in percentages healed wounds present for less than 2 months is very important. You can see here in the gray curve that the effect was much better and higher in the group where the wound was treated as early as possible. And I want to come back because it was so well presented by Kim that we have to remind 2 things. We need to do better prevention. And once the wound is there, it's the art of all of us to have an early diagnosis, one. And once there is an early diagnosis of a wound, the UrgoStart treatment is to start as early as possible with high evidence. And then we can gain a lot of suffering and costs. I like to share with you some slides of what were the ulcers. And I remember when I saw them first, it's now quite some time ago when I saw them first, When I started my diabetic foot career, let's say it in this way, more than 30 years ago, at that time I would consider those ulcers more as neuropathic. Now, over the years, we have understood that these lesions are mixed and that the ischemic part is quite important too. So how does UrgoStart work? I think it's important to understand there are two important elements. Excess MMPs that harm healthy tissue. The good news is that the TLCON product helps us, the UrgoStart Plus, inhibit exactly the excess of the MMPs. Wonderful. And that's not the only thing. A little bit later, it was clear to all of us that many of those ulcers, as already said, there is a part of ischemic or vascular issue, also on the microcirculation, that exactly the product can promote the growth of new blood vessels. So it's honestly magic. So as already mentioned, there is a circle for us in diabetic foot care, ulcer care, that we have to respect. Of course, metabolic control, of course, vascular management. So be careful. The study will never say that if you have a mixed ulcer, neuropathic ischemic, that this treatment will replace vascular management. Not at all. Infection management and, crucial for all of us, the offloading. And then comes in local care. Debridement, yes, of course. The circle starts again. Local care, but here, effective local treatment. And this is, for me, in history, we were so proud in our society to say, now we have a study, top-level study, with evidence. Clinical evidence, another wonderful thing, not complex, easy to implement in clinical practice, and address local factors that impede healing. So coming back to what Kim said, how do we move from clinical evidence, day-to-day practice, with every time this little timer in it? The sooner the better. Guidance documents we have, we need practical tools, and we need pathways. And I was really happy, at least for Europe, we worked quite hard with really dynamic people to think about fast track, how to have quicker access to the patients at early stage, the pathways. Before I will go in detail on that, what an honor for all of us. I was in the early years already partner of the International Working Group guidance with Karel Acker. And in those guidelines today, there was really clearly said in the announcement that this is considered the use of sucrose octosulfate in pregnant dressing in non-infected neuroischemic diabetic foot ulcer, despite the best standard of care. It's like we have to follow this guidance. So it's the first time ever that a dressing is recommended by the International Working Group in the treatment of diabetic foot ulcers, and more to come. Publication later on in October 2019, effectiveness of intervention to enhance healing of chronic foot ulcers in diabetes, a systematic review with, again, quite some important key opinion leaders saying to us, the efficacy of sucrose octosulfate in pregnant dressing have been shown in large, well-randomized trials, both at low risk of bias. And see what is said next. Addition to standard of care in neuroischemic ulcers. So myself contributed quite some time in the pathway, and this was already presented also last year, and we worked together in your committee on the concept how to work with a kind of a tool that can be adapted in so many different countries on a fast track pathway. We have not the time to go in detail, but the concept was there that we can have very simple definitions on uncomplicated foot ulcers, complicated, severe. Some countries put a yellow ulcer classification in it, but the most important is that we said, listen, This is also to work together with the GPs, with the nurses, the district nurses. Here you need to be connected with a specialized center. And here, for all of us, it's like a myocardial infarction. You have to go quickly for care and not extend. And then we put for all these tools the principles of standard of care. And it was the first time ever in this kind of pathways we could absolutely say this is the product to use. The nice thing is that when we were now in this COVID period, we have to rethink totally our model of care. And again, with the International Diabetic Food Care Group, I may not say the young academics, because at the meantime, they are really having a nice career too, but it's a dynamic group with the International Group of DFood who worked on the new model during post-COVID. And I want to share 2-3 slides to finish with my presentation, is that we need now today, when we have went through the different waves of COVID, and some of us have more and others have less, to think about the patient triage and to think which patient needs absolutely hospital care and preferable not in hospital because of this COVID situation. So, and more and more we will, as we are now online for this presentation, also medicine will change tremendously on the globe with telemedicine. So what was wonderful, and I have to applaud to all the initiative takers with the International Working Group, with the DFood, with so many other groups, the experts put an adapted guidance document online for COVID. And it's an interactive where everybody can put questions. By this, and we are working on documents to help on the globe on all these diabetic foot care people. 3 items we have to reschedule. Triage, who needs which care with the colors, emergency, priority, non-urgent. Do we really need hospital? Can't we be more clever to decentralize our care with, of course, having the need of a multidisciplinary teams in our areas? And how to consider in a proper way the alternative care online with good pictures and so on. So in one of my presentations, because I have quite some presentations on this COVID, I want to share with you some basic concepts. We need to work hard on decentralization of diabetic foot care, empowerment of community-based healthcare, yes, telemedicine, but also look for treatment that is so simple and with evidence that we can help the family and the self-care to get at an early stage the right care. And now I make a statement, probably that is hard, but I'm so convinced, working on so many years on the international level, that we have to overcome the myth that wound care is a common and often stressful family caregiving task. Yes, if we talk about negative pressure treatment and very complex treatment, yes, we may not leave it in the hands for the family because it gives stress to them. But today we have an evidence-based dressing, a simple one. It's shown that clearly that we can gain time. It has been shown that we have to use it early. So we have now the obligation, let's detect early. At the early start, we can use simple evidence dressings, and we can probably invest more with family care. If the caregivers are having not the same access as we had before our COVID, let's rethink the model and let's be proud we have the best care today. So yes, on top of it, we have to rely more on podiatry and district nurses, especially in the post and per-COVID time. So that's what I wanted to bring to you, that we have, before we were aware that COVID was coming to us, we had these wonderful studies done, and now we can even do the statement again. Early detection, prevention of course, early detection, and let's use the products that are very important in the first line in time. So now I'm very happy to introduce the next speaker, who will be the other part of the package on the lower limb ulcers, and it's a pleasure to introduce Jeanette Milne.
Thanks, Kristien. Brilliant session on the importance of the things that we need to consider in the diabetic foot. Like you said, I'm going to talk to you about the lower limb wounds and the venous and mixed arteriovenous leg ulcers. I'd like to thank Wounds Canada for giving me the opportunity to speak to you all today and share our experiences in the UK. I think the key considerations when you develop any clinical pathway need to be around evidence-based practice. Not just the clinical evidence, but really the guidelines are consistent with the best practice statements and consistent with the ease of use and ease of implementation for the caregiver, and never more so, as Kristien said, in relation to COVID. We need those guidelines to be easily implemented by our caregivers and patients themselves. And it's really important when we do anything in practice that we monitor the impact of that and look at the healing outcomes and the costs associated with the care that we give to our patients. If we get it right, there is a tangible link to that cost being lower for the payers. In my case, that is the National Health Service. But when we get it wrong, and as is the case sometimes in the UK currently, we are currently spending £5.3 billion per annum on wound care. And the most important factor in that is getting rid of inconsistencies of care and trying to reduce the variation. And I hope you'll agree that when we do that, we not only get best practice to our patients, but we improve the experience of care and get them healed sooner. In keeping with that evidence triangle, I'm going to talk you through the challenge double-blind randomized control trial that again was the first of its kind, looking at venous leg ulcers with regards to specifically looking at a contact dressing. You will know that we've got other leg ulcer studies which have looked at purely the compression component, but this study sought to make sure patients were in best standard care, but also wanted to see the impact of a dressing. And that dressing was able to be double-blinded because Urgo have a similar product that looks to the caregiver exactly the same. So the caregiver didn't know which dressing they were using. So it was a double-blinded randomized control trial. With the patients had either a venous leg ulcer or a mixed leg ulcer, and they were specifically looking at wound area reduction. The 45 centres were in France, and there was an 8-week treatment for the patients, and 93% of patients you'll see here were in compression. Outstanding results for, again, the TLC NOSF product. You can see here that the treatment arms were matched in terms of numbers, but there was a statistically significant wound area reduction in the patient group that were using the TLC NOSF dressing. Incidental findings of the study were around quality of life with UrgoStart. Patients had less pain and discomfort and less anxiety and depression. And I might be making an additional leap here in terms of the data, but just in relation to managing these patients on a day-to-day basis in clinics across the Northumbria region of the north of England, when patients see a tangible difference in the size and the volume of their wound, that has a huge psychological impact, and that psychological impact will obviously have played out in these findings. So being a skeptic, as a lot of clinicians are, we can always say that yes, a randomized control trial has the Hawthorne effect, if you like, those patients are in a study, the clinicians doing that study are really motivated, they're seeing the differences, and we struggle to believe that it would work in the real world where everything wasn't as ordered as perhaps it is within the inclusion and exclusion criteria of a study. So Ergo sought to look at real life data on patients with both VLUs, diabetic foot ulcers and pressure ulcers, and they pooled the data from 8 observational studies that they had and looked at the time to complete closure. So this was over 10,000 patients with various wound types, as I said. 77% were venous leg ulcers, again in France, but also in Germany this time. And you can see here the average days to closure, 111 days on average with UrgoStart for a venous leg ulcer. And you will see that and comparing to some of your practice and some of the outcomes that you may well have had for your patients, that stacks up really well against that, 70% of venous leg ulcers will heal at 12 weeks. This was much sooner than that. So I think, again, it gives you confidence that real life is consistent with the results observed in the RCT. So we also, as Kristien said, had the published study on the diabetic foot. Lots of healthcare authorities were looking at this data, and Ergo was submitting this data to our healthcare authorities. It was included in the international guidelines for the diabetic foot, and also had a lot of health economic analysis in terms of reducing that cost and the impact that reducing that cost would have. I think there's always a bit of resistance from payers to sometimes pay for a more expensive product. However, we are the most expensive aspect of any intervention with our patients. The staff costs, the clinic costs, the overhead, the driving to see patients in their own home, that by far drives the biggest cost. So in the UK, the biggest academic sort of institution as far as NICE is concerned is the National Institute of Clinical Excellence, and they are linked to the NHS. They're an independent body and they look at evidence, and UrgoStart was the first dressing to be recommended. They found, on reviewing all of the evidence that was submitted to them independently of Ergo had to prepare an amazing amount of evidence to send into NICE, but they found on the side of the product in that they fully concorded that UrgoStart dressings are proven to reduce healing times for patients and improve the quality of life. And there were significant cost savings for the NHS. So for the first time, we had randomized control trials, we had real world evidence, we have the economic evidence. But again, in terms of taking that to the organisation, there is often a reluctance to believe that in the hands of our nurses that we would see the same thing. So what we did in Northumbria was we set our research nurses away with a small study to try and replicate the real world data. So we asked the district nurses to pass over to our research nurses patients with lower leg wounds that weren't diabetic foot ulcers. We, or the research nurses, looked at standardising the care for those patients. So again, they had that same 4-week run-in period that we made sure that their care was optimal. So they were in compression, they'd had an ABPI, and they were in compression that was suitable for their level of disease. We also did not introduce the UrgoStart product for those first 4 weeks. The product was then introduced at the 4-week point, and we again looked at that wound area reduction, and I just want to show some of the cases that we got. Those cases were very much driven around the pathway that we know needs to be accompanied with anything that we do. As far as we wanted to maintain that, we wanted to reduce the variation in leg ulcer care. So that was about assessing the leg ulcer risk and implementing preventative care if possible. But if not, we wanted to assess and make sure diagnosis, ankle to brachial pressure index, and onward referral if appropriate. For example, if a vascular intervention could benefit our patients, but then reliable implementation of treatment. So like I said, we put patients into compression for that first 4 weeks and optimised their therapy before we introduced this. A number of the patients had had their ulcer for a significant period of time and were in compression. So these were not new ulcers that we were seeing in this 10-patient cohort that we did. What we did find, incidentally, was that patients weren't having limb washing. Some patients weren't allowing staff to limb wash. Patients across our community sometimes weren't in compression, and patients were in reduced compression when they should be in full compression. And patients overall, we felt, should be transitioned to hosiery and self-care sooner, which we have seen dramatically in the COVID pandemic, but perhaps weren't seeing pre, which was when we collected this data. There was a huge amount of confusion in the community around the amount of different hosiery kits, the wraps, and when to use different classes of compression. We have British standard, we have European standard, and that causes confusion. And obviously we knew that the NICE guidance had been granted to Urgo, and Urgo were trying to convince us to implement this guidance in practice, but we wanted to see for ourselves whether it would work. The prognostic indicators that we used were wound volume and area reduction week on week, and looking also to acknowledge the factors that affected healing, and also what the patient priorities were, what their comorbidities were, and that recognition of the differentiation between inflammation and local and systemic infection. And where appropriate, during this 10-week period of monitoring these patients, if there were signs of infection, we intervened with topical antimicrobials, and again, if they had comorbidities, we did try to optimize their baseline treatments for these. So this is one of those patients. This patient had had their ulcer for 5 months duration. They were in compression on enrolment, but we again had that 4-week lead-in period, and you can see here the ulcer size at the start of UrgoStart being applied, and you can see here the healed ulcer at 28 days. So a dramatic improvement for this patient, and again it started to give us confidence. This is another patient with an ulcer of 5 months duration, and you can see here on the left, after the patient had been optimized in treatment with compression, and again a 3-week duration to this second picture on your screen. So of the 10 patients, we saw healing in 7 of them during the 12-week period. The 2 patients that we saw initial improvement were again, to go back to Kristien's point, which was around the fact that those patients had had at enrolment their ulcers for 22 months in duration. But this gave us huge confidence. But then again, it was kind of, what do we do now? This was research. It was research nurses that were knowledgeable in tissue viability. It was a small cohort of patients. So we then opted to give this product to one of our district nurse teams and said, you know, go away and look at this and apply it to your venous leg ulcer patients. And this is some of the clinician feedback that we got in doing that. So they took it into their clinic. we also gave them a wound area reduction tool so they could track wound area reduction for their patients, and they started to use it. Now, the difference that we found in clinical practice that we perhaps had tried to reflect the randomised control trial and give it a run-in was that the community nurses found it much easier to do that upfront assessment of their venous patients, get their ABPI, put them into compression, and if the wound itself was clear of slough and necrosis and didn't need any debridement, they found it easiest to put UrgoStart on from the beginning, to miss out that run-in step. And in doing so, they got really good feedback from their patients. And this, I'm sure you've had a chance to read this slide. Brilliant feedback from the clinicians as well. You know, the clinical outcomes had increased, and they had standardized their care, and they were measuring their wounds at every week. And as a team, they found increased motivation during the healing times, and that they were celebrating good practice. And in the UK, they have been highly commended for this work at the Journal of Woundcare and British Journal of Nursing Awards this year. So I think it's really boosted that team morale. It's reduced the variation across the team, and we've now started to roll that out across all of our district nursing teams, because this was one distinct district nursing team that we gave it to initially. So I'm sure you'll agree with me that this gave us huge reassurance that we could give it to nurses at the coalface, and it would still replicate that randomised control study evidence and the evidence of the tissue viability nursing colleagues. So what does it mean for practice? For clinicians, it means that we're releasing time to care, and it improves patient outcomes. It increases those ulcer-free days and reduces pain and improves the quality of life for your patient. And that's why most nurses come to work, isn't it? I can't express enough that when I've had a really difficult day managing the politics of being a large organisation and managing a large group of nurses and a large group of patients, that my days in clinic are what reaffirm to me the reason that I am a nurse. And that is really what it's all about improving the outcomes for our patients. But interestingly, and alongside that, for the health economy, reducing variation releases cash releasing savings, and you know, those cash releasing savings aren't in my organisation being taken out of nursing hours. We are ploughing those back in to improving care in other areas. So we're keeping the same number of nurses, and we're, you know, rolling out this best practice. This just shows the spend of the team that I gave this product to. So you can see here on the screen that they were tracking above their month-on-month spend for their dressings, and introducing UrgoStart and the wound area reduction tool brought their spend under. And I have no doubt in my mind that that is because they were healing patients sooner. So this premium product gave us reductions in the overall expenditure for this district nursing team, and, you know, gave them also confidence to continue using that product. And they have started to use it in pressure ulcers and also in post-surgical wounds as well. Diabetic foot and leg ulcers represent a high burden of wounds to our society, and the objective is to reduce healing. UrgoStart has shown superior efficacy to reduce healing times and improve or reduce costs to the peers, if you like. So in my case, the NHS, and that is when comparing it to neutral dressings. And that's been confirmed through real life data, in meta-analysis, and in the randomised control trials. And it definitely has been borne out in my practice, as I've shared. So it's really important that we use UrgoStart for our patients, and it will add value, but to use it first line and to use it as soon as possible, because that definitely is borne out in the data. UrgoStart has been recommended internationally by guidelines for diabetic foot and in leg ulcers, and it's really, really easy to implement pathways that enable the implementation of UrgoStart to improve the healing outcome for your patients. And that is why we go to work. We go to work to improve the outcomes of our patients. Never more so in a COVID world has it been important to do so. And UrgoStart is addressing is really simple to apply, simple to remove, doesn't cause any pain on removal, doesn't stick, and can be easily used by our patients under compression kits. And we are already seeing increases in the rates of amputation across Europe. And Kim very much pointed out what the potential impact of this product could be across Canada during her slides in the beginning of this presentation. So I would urge you to seek out Urgo and learn more. I'd like to thank you for attending this session today. I'd like to thank Wounds Canada, and I'd like to thank Urgo for hosting this session. You can find more information on UrgoStart at the website below, and obviously you can request samples also.
Good morning, everyone. Well, thank you so much for joining us this morning. We're now going to open this up to questions and answers. I'm thrilled. We have so many questions that have come in. Hopefully, we'll be able to get through a lot of them. I'm trying to kind of clump them all together. We have had a lot of questions around, is this available in Canada? So the answer is yes. Please visit the Urgo booth, and they can give you all the information as to where you can get samples, where you can find out costing, and as well how readily available it is in your community. So please go visit the Urgo booth. There's a break right after this session, so please go then, and they can answer that question specifically to your local area, but it is available across Canada. Now, one of the things that we do have another question about is we do have an expert with us today. We have Diabetologist with us who can answer a few questions, really more of this from a scientific perspective. So I'm going to ask this first question to you, Diabetologist, if you want to come on. So one of the big questions that has come up multiple times throughout the chat is wondering if you can explain a little bit around the similarities between UrgoStart and Prisma Promogran, and its role around MMPs and proteins, and also how does a sucrose oxysulfate, which you know I can't pronounce that properly, work in the wound bed to bind MMPs and to stimulate angiogenesis. Diabetologist, do you want to comment on that?
Yeah, that's a great question. The honest answer is that this is a subject of continued research. Sucrose octasulfate is a highly ionic molecule. It's a potassium salt of sucrose octasulfate. So when you put it in the wound environment, it dissociates. And that ionic charge has probably something to do with how it binds to the MMPs. It's not a neutral molecule. It is a charged molecule. Similarly, with respect to angiogenesis, there are a lot of angiogenic factors at play. And these charged molecules can have suppressive actions or amplifying action on the enzymes and various factors involved in angiogenesis. Net-net, though, it appears that the sucrose octasulfate charged molecule elicits a healing response. With respect to difference between Promogran and Prisma, I would say that based on what little I know is that the products are comparably priced based on, again, I'm not a commercial guy. But what I can tell you is that the RCT that we have is far more robust than what Promogran and Prisma I have seen. with respect to the number of patients done and so on and so forth. So the clinical results are fairly remarkable, and that is what differentiates it from the other product that you mentioned.
Great, thank you, Debashis. So now, Jeanette, I've got some questions for you that have come in, and these ones are quite interesting, from a clinical perspective. So what they're asking is, how did you go about using this clinically? How long can the dressing stay in place? What did you see when you were changing it? How did it work under compression? And particularly if you weren't able to completely offload someone with a diabetic foot ulcer, in your opinion, would it still be appropriate to use?
Thanks, Kim. From a point of view of how long can it stay in place, it can stay in place for up to 7 days. It comes in various formats with relation to obviously answering the question about how does it do under compression. You can get a simple wound contact format that's very much like UrgoTool, but obviously has the NOSF in that format, or you can get it in a slightly thicker pad, and you can get it in a foam version as well. So I think, it has something for everybody in it. So if you've got slightly increased exudate, you may want to use the foam. In the diabetic foot and the offloading example, you might want to use the wound contact version. But it's very versatile. In terms of what you see initially, I think sometimes you will see an increase in exudate, but it's about not being afraid by that. I think that's commonly reported in the literature, and it's very much about that kind of transition phase within the wound as the chemistry is changing within the wound itself, and then you start to see the progression towards healing.
Excellent. So another great question that has come in is looking around arterial compromise. So if you have a patient who has mixed, say a mixed ulcer on their lower leg, or they do have more severe arterial insufficiency, would you consider using this product on those patients, or is it more that you would wait until they've had revascularization?
So I personally would wait until I had revascularization.
Certainly from my perspective, I would probably look to see, is it cost effective to try this now? If I can get my patient revascularized, then I would certainly, obviously look for revascularization. In some cases though, where we can't get revascularization, I think that it might be worth trying. If it's some of my long-term care patients, we don't really have that option of getting them revascularized.
Kim, the other thing from my perspective is that of the 10 patient cohort that I talked about, the research nurses talked about, a lot of them had had a wound for a long time, and a lot of them were mixed arteriovenous ulceration. So I think it really depends on the extreme nature. I think if you're somewhere in the middle, then this product will work. As we all know, if you're in critical ischemia, very little will work other than revascularization.
Exactly. I think that certainly, it's a matter of, we don't necessarily want to be just throwing everything at our patients. However, we have to make sure that we're taking into account the fact that we have to remove all the causes and control all of the modifiable variables that we possibly can. And it's a team approach. I think that's the other thing. We don't want to be just throwing this on all patients without looking at that complete team approach and making sure that we are getting the full team thrown at them, so to speak, because it does take a village. So at this point, we are coming to the end, so I am going to have to thank everybody once again for joining us. I'd like to thank Urgo Medical for sponsoring this session, for Wounds Canada for having us, and please go to the Urgo Medical booth. We will try to get to the rest of your questions through the chat sections, but please go visit the Urgo Medical booth. There's a break right now, so go to the booth, and hopefully you can get a lot of your questions answered there. Thank you so much again for joining us, and thank you to Urgo Medical for having us. Kristien and Jeanette, thank you so much for joining us from across the pond.
Thanks.